Morning, everybody. Welcome to the, is it the last talk of the year?
Oh,
Oh, sorry. Yeah, it's the last important, I'm sorry. No. All right. This is presented by the Department or Division of Nephrology. Our speaker is Dr. Diana. She is an integral part of this hospital, the university. Hopefully she'll be with us forever and ever and never, ever leave. So organ transplantation really is quite miraculous. And what's interesting is that we can't get enough when in actual fact you have spare organs, all right? You don't really need everything you have. So why don't you give some of it away? It's a great way to lose weight. Anyway, so Dr. Diana will find out why people just won't give their organs away. Thank you.
Thanks for the great introduction, Professor Paget, as always. Okay, so I'm going to be talking about barriers to transplantation and what potential solutions there are to these barriers. So first, I'm sure we all agree that kidney transplantation is good, right? Compared to dialysis, it provides a better quality of life, it provides mortality benefit, and it's cheaper to the healthcare system. So we should all be getting patients to minimize their dialysis time and get them transplanted early. So the International Society of Nephrology put out this document in 2020, and it highlights the importance of a transplant as part of the care package or treatment program for patients with end-stage kidney disease. And they outline the requirements for an effective transplant program, which is nicely summarized in this pyramid on the right-hand side. And they say for an effective transplant program, you need buy-in or commitment from the government at a national level, at a provincial level, at a regional level, as well as buy-in from hospitals, buy-in from healthcare workers, communities, and patients' families. So it sounds simple, right? So why is there such a huge difference between patients who've got end-stage kidney disease who are on the waiting list for transplant versus the number of patients who are actually receiving a transplant? Okay, and this is related to, if we look on the right-hand side, this is related to the continuous increase in global burden of end-stage kidney disease. It's just relentless. It's the number of patients on the waiting list versus the number of transplants that are actually happening, which is increasing at a much slower rate. So in the US, 20 patients on the waiting list for kidneys every day die waiting for a kidney. So what about South Africa? By 2030, it's estimated that more than 70% of the world's population with end-stage kidney disease will reside right here in middle and low-income countries. And this is a problem because these countries have limited funds to deal with renal problems because they're using their whole healthcare budget on communicable diseases. So the South African Renal Registry documents how many patients have got kidney disease and how many are on dialysis and how many have been transplanted. So this is data from 2019, because in 2020 it dipped because of COVID. We had almost 10,000 patients on dialysis, and almost 900 started in 2019. We've got 291 dialysis centers in the country, of which 88% are in the private sector. There are 7 transplant sectors in state, and there's also 7 transplant sectors in the private sector. So how are we doing compared to the rest of the world for transplant? In Europe and America, transplant rates are much higher. In Europe, it's at 35.5 per population million, and in America, it's at 40.5 per million population. In Africa, we have very few transplant centers. Most African countries don't have the ability to do a kidney transplant. And in South Africa, we're only doing 6.4 per population million transplants per year. So why are we so far behind, right? We can do a transplant. So there's this growing burden of end-stage kidney disease, and those of you who have rotated through renal, we see it all the time, right? There's just this relentless increase in number of patients who've got kidney disease. And it's related to the fact that we have a diseased population. We have the highest rates of hypertension and obesity in sub-Saharan Africa. We have the biggest burden of HIV in the world. And these patients are often younger and present late. You know, our primary healthcare system in the country is not great. So patients aren't referred, they aren't picked up early. Patients don't go for screening. So they're presenting to us late, and they already have ESRD. We also, some of our population have high-risk genotypes for kidney disease, like the APOL1 genotype. The next issue is we don't have enough trained personnel. In the whole country, there are only about 117 nephrologists, and we are considered an upper middle income country. So we have 2.5 nephrologists per million population. Other upper middle income countries have double that at 5.1. And the US has 10 times as many nephrologists as we do per million population. The next issue is you need someone to put the kidney in. We've got less than 20 transplant surgeons in the whole country. And in 2015, we only had 22 transplant coordinators in the entire country. So this number is growing. The next issue on why we're so far behind is we don't have enough donors. We don't have enough deceased donors. We don't have enough people coming forward to be living donors. So these are the numbers of kidney transplants in South Africa. And in 2019, we did 224 transplants. Sounds like a lot, but remember, we've got 10,000 patients on dialysis in 2019. And so let's imagine half of them are transplantable. That's 5,000 people. So if we're doing, let's say we had a bumper year and we do 250 transplants, it's going to take 20 years to transplant the patients who are currently on the waiting list waiting for a kidney. That's with no additions. Remember, we're adding 900 people a year. So we are not on top of this. Okay, so the first barrier is probably lack of transplant education. So lack of transplant education, there's this general lack of knowledge around organ transplant and organ awareness and organ donation, like what is a donation, what does it mean, how do you register? There's a lack of education around the concepts and diagnosis of brain death. There's a lack of education about referral pathways. I don't know how many people in this room know how to refer a kidney to our transplant sisters who are literally one floor up. There's a lack of ability to communicate around organ donation and consent from donation. People are scared to approach families whose loved ones are in the ICU brain dead for organs. You know, how do you ask them in this dreadful time to give away their family's organs? So we'll have a look at a few of these. Yeah, so this study was done at a tertiary hospital in Limpopo, and they surveyed 300 people who came to the general outpatients department, and they asked them about their attitudes and potential barriers to transplant in South Africa. And shockingly, only 13.3% of people are willing to donate a kidney. Can you imagine? 13%. These are people who are in the hospital. Okay, and their biggest concerns were that it may change their body after donation, and that there may be complications after the kidney transplant. That is their concern about the transplant and why they wouldn't donate. And what they felt the barriers to transplant were that cultural beliefs were preventing them from donating a kidney at 61%, and 86% were scared to donate a kidney. Quite shocking statistics. Okay, so there is good evidence that organ donation rates increase or decrease depending on what the healthcare worker's attitude is towards organ transplant. Okay. So the study was done in Nigeria, and it was done in healthcare workers. The survey was done, it was a self-administered survey, and it was done at a pediatric conference. So pediatric people are nice, right? Nurses and doctors look after children, they're nice people. So only 50.7% of them would donate a kidney. That's not nice. 56.5% of doctors and 33.9% of nurses, but 76% of them would accept a kidney. So these are healthcare professionals, right? They are quite willing to accept you giving them a kidney, but only 50% of them would be willing to give a kidney to another person. And that's quite shocking. We'll be harvesting kidneys at the door, by the way. I'm just joking for those of you online. Okay, so what is the healthcare workers in South Africa's attitude towards transplant? These are two of the studies I could find. The first one on the left was done in nurses in Johannesburg, and it looked at their attitudes towards transplantation in the state and the private sector. And overall, the attitudes of nurses towards transplant were good. Just over 80% said that they themselves would refer people for transplantation if there was a proper protocol in place allowing them to do so. But shockingly, 60% of them didn't realize that there was already a protocol in place to be able to refer a patient. On the right-hand side, this is a study done at UCT about medical students' knowledge about brain death. And the final conclusion is medical students don't know how to declare brain death, and that it should probably be incorporated into the curriculum. So what can we do about these lack of education? What can we do? What are some solutions? So involving the general public. Should we be incorporating ideas about organ donation into the school syllabus, right? Should we start that young? And this is happening in the US and Japan. And they found that this, they introduced concepts around organ donation into the school syllabus, and it's promoted and promotes conversations at home between the scholars and their families, between communities. Because if you understand the ideas around organ donation, when you're suddenly faced with a decision later in life, it's not a completely foreign concept. Like, you want to cut out my mother's liver to give it to someone else. Like, what are you talking about? You know, these concepts have been introduced much earlier on in life. The next option is to have promotional activities and campaigns to first prevent organ disease. So, you know, remain healthy, don't get kidney disease, and then also around concepts related to organ donation and transplantation. There's also good evidence that if religious and community leaders are involved and are educating about transplant and are pro-transplant, that that outcomes are better, that people are more willing to be involved in transplantation. Healthcare professionals, we can play a big role, right? We can advocate for transplant. We can educate people about how important transplant is, how it changes lives, what the, you know, how many people are dying waiting for a dialysis, because in our setting, if you aren't transplantable, you don't get dialysis. If you are on dialysis, the only way to open a slot for someone who's waiting for dialysis is to be transplanted. We can also educate people about like how to declare brain death, you know, how to refer patients. And so aspects around healthcare and around organ donation. And then we can also look at how we communicate with our own patients and families and what impact that could potentially have on, you know, when you're asking for an organ. Yeah. What's also important is research, right? We need to do research, and we need to have transparent outcomes that are available for the public to look at to see what's happening with the transplant program. Okay, so this is about brain death, right? So the South African Medical Journal, as well as the South African Journal of Critical Care, published this guideline in 2021. It's an excellent guideline. I suggest you all read it. And it tells you how to declare brain death, how to declare circulatory death, and what the regulations, South African regulations are by law to be able to do this. And at the end of the article, it's got some handy sheets. One of these is this sheet on how to certify brain death. So in South Africa, you require 2 doctors to certify brain death. One has to be in independent practice for at least 5 years, but the 2 doctors can do the tests together, and it tells you what tests you need to do. Obviously, the doctors involved in the transplant team are not allowed to do these tests because they would be gaining the organs. Also, there are these 2 other handy sheet summaries that tell you what tests need to happen and how you're going to be able to do these tests to declare brain death and apnea testing. The same year, the NEJM also put out an article about how to determine brain death. Also a great article. What's nice about this is there's a video attached to this article that actually shows you how to do the tests for brainstem testing to declare brain death. Okay, our next barrier is that we don't have enough deceased donors. So why don't we have enough deceased donors? Well, first of all, healthcare professionals can't declare brain death, right? They're unsure about how to declare brain death. It's a big decision, right? Declare someone brain dead. But if you have the knowledge and the patient's brain dead, there's nothing you can do for the patient, right? We might as well be using their organs. You don't know how to refer the patient or where to refer the patient to. Like, you know, you're out in some hospital, you're out at Edenvale. You don't know where to phone. Who do you phone? Usually you phone me, but anyway. And you don't know how to approach patients. You don't know how to start the conversation with the families to be able to procure the organs. There's also, we'll look at some of these issues in more detail. There's also, maybe the families will refuse. Okay? There is a lack of funding. And then we'll talk about an opt-in versus an opt-out policy for donation. Okay, so why do families refuse? Families mainly refuse because they are unaware of the donor's wishes. They've never had a conversation with the donor, or, you know, the patient who's now brain dead in ICU. They've never had a conversation about what do you want to do with your organs. It's very difficult to make a decision on someone else's behalf if you've never had the conversation. Okay, they themselves don't have knowledge about donation or what it means to be brain dead. You know, I'm telling you that your loved one's dead, but the heart monitor is still going and they're still breathing because of the ventilator. What do you mean the patient's dead? They're not dead. So they don't understand the concept of brain death. There's also issues around medical mistrust. There's been some scandals previously about organ donation and organ procurement. Families fear that the body may be mutilated while they're harvesting the organs. So there are a whole lot of reasons on why families may decide to refuse to proceed. Funding is a big issue, right? You require funding because a lot of these patients are in ICU ventilated. So they are blocking an ICU bed, particularly in a low resource setting like ours. They are blocking an ICU bed while they're dead, waiting to give their organs away, while someone else who's still alive and really sick needs the bed, right? They also need specialized nursing care until they can go to theatre to have their organs procured. So funding is a big deal. So what are some potential solutions here? Again, religious leaders, community leaders, support and involvement, and being pro-organ donation makes a big difference. And being pro-people donating their organs after death. You know, cultural beliefs are thought to be a big reason not to donate the organs. But if you speak to some of the religious leaders, this is not actually the case. And if they were more vocal about, you know, what is and isn't allowed in certain cultures and religions, we probably would have more deceased donors. We need, things will be much easier if we had a protocol on how to declare brain death, if we had a protocol on how to refer patients, if we had dedicated ICU services and operating time for these cases. What if we use other organs, and not only after brain death? What if we use organs after circulatory death? So we'll talk about that. And then what if we transplant against the histocompatibility barriers? So we don't find the perfect organ for you. We find an organ that doesn't quite match. Can we manipulate your immune system to make you accept it? Then we'll talk about having an opt-out policy for transplant, and we'll also talk about some xenotransplantation. Okay, so this is an article from the UK. It's registered, and no, this is not registry data. This is they looked at all the people who were referred to the transplant coordinators in the UK for transplantation, for deceased donation, and it included about 4,900 people. And the article concluded that the ability to gain consent for the donation was mainly related to two factors. One was knowing what the patient wanted, so knowing what the individual's needs and wants were. So particularly if they had an organ donation card, or if they had if they'd had a previous conversation about organ donation, so they knew what the wishes were of the patient. And the second was the involvement of a specialized transplant coordinator or a specialized nursing sister who had an idea about what is transplant, what's the process, what's going to happen. Okay, so can we do donation after circulatory death instead of after brain death, right? So this is after the circulation stops. And on the left-hand side, the red bars show that the countries that are doing donation after circulatory death. So there's quite a few happening in Spain. And on the right, you can see, this is data from the UK again, and you can see that over time, there's been a massive increase in number of donation after circulatory death in the UK, and it's added to the numbers of transplants that are happening. So, I mean, if you think in 2019, 2020, they did 634 organ donations after circulatory death. Remember, we only did 224 in total. And their population is similar to ours. Okay, so the concern if you donate your organ after circulatory death is, are you getting an inferior organ? No, the circulation is stopped, right? So this is registry data, and it includes more than 13,000 patients with the brain death and the circulatory death patients. And you can see that circulatory death accounted for more than a third of their transplants. So it boosted their numbers by more than a third. And yes, they did have longer delayed graft function, which means the kidneys took longer to start working. But at 5 years, the GFRs were similar. And at 10 years, the graft survival was also similar. So you're not getting an inferior organ. Graft outcomes are still good. Okay, so what about an opt-in versus an opt-out policy? In South Africa, we're an opt-in country. When the time comes, you get to decide that you want to opt in to donate your organs. But somewhere like Spain is what's called an opt-out country. All the citizens of Spain know that when you die, if you're suitable to be an organ donor, you will donate your organs, unless your family or you have opted out. Okay, so there is data that suggests that opt-out countries have more organ transplants than opt-in countries. But this data from 2019 shows actually that this rates of transplantation from opt-out and opt-in countries are quite similar. And this is because in opt-in countries, while there are fewer deceased organ donations, there's a lot more live donors that happen. Because in opt-out countries, the people feel that they're going to donate their organs when they die anyway. So why should they give them away as a living donor before that? This review was published in 2021 by Harriet Etheridge, who is a biomedical ethicist who used to be at Donald Gordon. And she looked at countries that had switched from being opt-in to opt-out. And was there an increase in the numbers of transplant and what effect did this have? And she concluded that the simple switching between an opt-in to opt-out didn't increase the donor numbers. It was everything that went with it, about public awareness and government support and so education, everything that went with it. It wasn't just the switching from opt-in to opt-out. So there's also some ethical issues around this, right? Can you imagine tomorrow Cyril announces we're all donating our organs, right? Like there's going to be public outcry, and there needs to be a whole lot of education for this to go smoothly, and funding, lots and lots of money. Okay, so what about xenotransplantation? Xenotransplantation was first done in the 60s, and they used chimpanzees because they're genetically similar to us. But the problem with chimpanzees is they're an endangered species, so they're not a great source of organs to fix our organ problem. So in the 1990s, they decided pigs would be our answer, right? Pigs are evidently easy to grow, and pigs would be our answer to this problem. But the problem with pigs is they obviously have a genetic differences to us, and humans have immune natural antibodies to porcine antigens. And so if you transplant the organ, it immediately gets rejected by hyperacute rejection. The body is clever. It knows the pig's organ is not its own organ. And so there's been a lot of interest around this in the past few years. So they've genetically modified pigs to try and change the cell markers so that our natural antibodies don't immediately reject the organ. And we haven't been very successful yet. They did the first heart transplant in 2022, and it lasted 2 months. They did the second heart transplant in 2023, and it lasted 6 weeks. And they did the first kidney transplant earlier this year, and it lasted 2 months. So we're not getting there yet. But watch this space. Okay, so our next barrier is we don't have enough living donors. Okay, so why don't we have enough living donors? There's lots of us living, right? You don't need both kidneys. Okay, so again, a lack of knowledge. People don't realize you don't need both kidneys. People don't realize that before you come to, we don't cut out the kidney at the door when you arrive here to donate an organ. You have to go through many vigorous tests to pass to be able to be a super healthy human, to be able to give away your kidney. And our main priority is to the donor. We would never want to swap one patient on dialysis for another patient on dialysis. So our main priority is to ensure that the donor is super healthy, and if they give away their kidney, the risk of anything bad happening to them is very low. Okay, so there is a medical risk to the donor, obviously, and in the US data, the greatest long-term risk is seen in Black African donors. There's an element of medical mistrust because of the previous international organ trafficking scandals, and there's still organ trafficking going on not nationwide, internationally, hopefully not nationwide, internationally. And donors come forward, but they fail the tests. They don't get to donate the kidney, and we'll have a look at those reasons now. So this article was published last year, and it's from data from our own transplant unit. We looked at 1,208 people who came forward to donate their kidney between 1985 and 2015 here at our clinic, and we have a diseased population. Only 24.7% of those people ended up donating their kidney. So under a quarter. So 1,200 people came forward because they were willing to donate their kidney, but only 298 actually ended up donating their kidney. So 910 were excluded. And if we look at the exclusion criteria, the biggest exclusion was medical. We found patients with undiagnosed all sorts of stuff. So particularly hypertension, obesity, underlying kidney disease, and HIV infection. Then the next barrier was psychosocial. 97% of people, after hearing what donation meant, decided to voluntarily withdraw from the process. And then ABO incompatibility, so that's 10.5%, and a positive cross match. So basically the organ didn't match you. So the organ didn't match the recipient. That was 19%. So there were many reasons on why people didn't donate. But it's disappointing that of all the people who came, only a quarter were able to give away their kidney to someone who really needed it. So we looked at, we compared Black to non-Black population, and we found that Black donors were more likely to fail to get to the point of transplantation. And that was because they had a lot of undiagnosed medical conditions. 85% of them didn't get to transplantation, and mainly because of undiagnosed hypertension, HIV, obesity. So we looked at the patients who did donate their kidney, right? So how are the donors doing after you gave away your kidney? And there's a concern internationally that Black donors do worse after giving away their kidney. I'm not talking about death. I'm talking about like their GFRs are slightly lower at 15 years. You know, they're not all dying. In our cohort, in fact, there was no difference between Black and non-Black donors at 5 years. The numbers are quite small because we're, you know, donors are super healthy humans. They don't want to come for follow-up. They feel great. So it's inconvenient for them to stop into our clinic here and say hello to us once a year. So of the 290 donors, we have just over 100 who actually followed up with us for 5 years. And there was no difference in blood pressures, no difference in proteinuria. And in fact, if you look here, the Black donors actually had better GFRs than the non-Black donors at 5 years. Okay, so what are some solutions to not having living donors? First, again, increased awareness, right? Increased awareness about the need for organs, increased awareness that you don't need both your kidneys, increased for awareness of like, where do you come? Where do you present? You know, where do you make yourself available? Increased awareness about living healthy. So if you do come forward to give your organ, you don't get excluded. Then we can have organ donor drives. Organ donor drives are in the UK linked to renewing your driver's license. And in fact, in South Africa, it's also linked to renewing your driver's license. I went to connect my driver's license from Marlborough last year, and they tore off the organ donor card and gave me my license and put the organ donor application in the bin. They didn't even give it to me. So it does actually happen in this country, but you have to get the person to hand over the piece of paper to the other person. So then they can throw it away at the front door if they want to, but at least they've had the choice, right? I asked the man what this was, and he was like, oh no, he doesn't know, it's not important. I mean, that's the attitude. It's concerning. Then people can visit your house and stalk you, just saying. Otherwise, social media, you know, we live in an age of social media, so social media campaigns can play a big role here. Can we transplant across the ABO blood barrier? Can an A person give a B person a kidney? So the answer is yes. It wouldn't be our first choice of transplant because there are a lot of risks associated with it. People getting these transplants often have no other choice. There's no other donor that's suitable. Bless you. No other donor that's suitable. They've been on the waiting list for a long time. They need a transplant. So these are not first-line donors who are not waiting, you know, who haven't been waiting for that long. And in general, the outcomes at 1 year, 1 year graft survival is quite similar. But 1 year is not a long time in terms of transplant. And the biggest risk is the risk of infections in the ABO incompatible group versus the ABO compatible. So if you transplant against the ABO barrier, the body doesn't like it, right? We have preformed antibodies, so you need to desensitize the patient. They need hardcore immune suppression, so their risk of infection is a lot greater, and their risk of dying from some infection-related cause is also a lot greater, and obviously the risk of rejection is a lot greater. So it is possible to do these transplants, and they have been done in the country, but the immunological risk and the infectious risk is big. What about something called a paired donation, right? So this is a live donation as well. And just say donor A can't give recipient A a kidney because they don't blood group match. But we also in our clinic have donor B and recipient B. And donor A blood group matches with recipient B, so this person can give the kidney to this person. And in exchange, their donor matches with this person. So they'll do an exchange transplant. What is shown in this diagram is this awesome superhuman arrives called an altruistic donor. So they pitch up and they're like, I don't need both organs. I want to give someone an organ. And first we think they're crazy and send them to psychologists 1,000 times. But this happens, right? And this person arrives and wants to get anyone who needs a kidney on the list, right? So we find the most suitable, we work them up and make sure there's no contraindications and they're not crazy and they're medically well. And then this can start what's called a domino chain. So none of these people match each other's blood groups, right? So this donor gives this recipient a kidney, freeing up their donor to give the next, freeing up their donor to give the next recipient a kidney, and it starts off this chain that goes all the way along. Okay. This is currently doesn't really happen in South Africa. But there's some big advantages to this, right? You remove the patients who get the kidneys from the waiting list. So people who are waiting for cadaveric kidneys move up the list. Okay? These people get transplanted earlier. So they are not having the morbidity and mortality related to dialysis. They get a living donor transplant rather than a deceased donor transplant on the list. It's better to get a kidney from a live person than someone who's passed away, and then you get a kidney. The outcomes are better. It's better than getting a kidney from your sister who doesn't blood group match you, and now you need a massive immune suppression, and there's the risk of death and rejection. It's better to get a kidney that's better matched. And it allows people who are what's called highly sensitized, which means they've got lots of antibodies to all sorts of things. They often are able to find a better matched kidney than from their own genetic pool. So how do these kidneys do, right? They do well because they're like live donor kidneys, right? So they do better. They do the same as if we'd done a direct, so I give my brother a kidney because we blood group match. They do as well as those, so other live donor kidneys. And they do better than cadaveric donors because, you know, those people got kidneys from people who have passed away. Yeah, so things get a bit more creative. And there's something called the trans-organ paired exchange. Okay, so this means that my brother needs a kidney, right? But for some kidney-related reason, I can't give my brother a kidney. And your brother needs a liver, but for some liver-related reason, you can't give your brother a liver. So I could give your brother a piece of my liver, and you could give my brother your kidney. Sounds magic, right? But there's obviously some concerns about it because of the surgical risks related to this are different. The chance of mortality in a kidney donation is 1 in 3,000, but the chance of mortality in donating a piece of your liver is 1 in 500. So the surgical risks are different. Okay. The next interesting option is something called the Advanced Donation Program, and this is happening in some countries. So I have someone who's got CKD who doesn't need a kidney yet, but there's someone on the waiting list who does need a kidney. And just say I'm getting to the age, just say it's my son that needs a kidney, who may need a kidney in future. And I'm getting on in age, like I am. And I can donate my kidney now to someone who needs it, and I get a voucher. So that when my recipient, my son needs a kidney, they can access the donor pool to receive a kidney. But it sounds a bit risky, right? Okay. Yeah. So in conclusion, and this is from Harriet Ettridge's article, it sums it up quite nicely, that the success of an organ donor process depends on clear communication. We need extensive government buy-in. We need widespread investment in human infrastructure, including at the hospital level, because we need specialized support and individuals who know how to declare brain death, who know how to handle these situations, know how to approach patients' families to ask for organs. We need technical support to be able to maintain the registries and the donor waiting lists, and to verify that the data is real. And we need to have accountability, and we need to make the system transparent so that it can be reviewed, so that we know there's no dodginess going on. And it's very important that the public trusts in this process, and public trust has been shown to boost numbers of organ transplant. So most of us are not going to have an influence on government policy, and none of us are bioengineering organs in our offices. So what we can do is to start the process of discussing organ transplant and the benefits of transplant and aspects around organ transplant, so that we can talk to our colleagues and talk to our patients' families and communities about transplant and how important it is. And that's why we're going to start with, are you an organ donor? We have that?